Okay, so good evening all of you. We are going to have a session of GIT. This is a very short session, only for 1 hour, one and a half hour, maybe 1 hour 15 minutes. So you know it's not, I hope now audio is clear, video is clear. Good evening to all of you. Anyone having black screen has to log out and log in again. Otherwise, I guess the audio and video should be okay. Anyone having black screen, just log out and log in again. I hope the problem will be resolved. Still no audio? Some people are saying no audio. So shall we start now? Is it okay? Yeah. So I guess video audio is okay and we can start now. So without wasting, yes, good. So Monica has written yes and Neerja and many more have written yes. So I think we can start now. Good, fine. Harshita too. So good evening all of you finally. And we are going to have a small session about 1 hour 15 minute session of GIT. Important topic. So I'm sure you know GIT is a major topic and we normally take 4 days to finish complete topic of GIT. So in 1 hour it's practically impossible to discuss even the important topics of GIT. I can just tell you which are the important topics and I'll cover some of them. So let's start with esophagus. Dekho, now I suspect that this year we will have more clinical questions. Rather than straightforward one-liners, you'll have more clinical questions. So in esophagus, if you are getting dysphagia, any patient dysphagia, 4 or 5 conditions you have to think of. One is Zenker, Webb's and ring, motility disorder and cancer. And out of these 4, I can assure you, you will get one question. Yeah, important topic definitely I'll tell you. So I'll repeat. So diverticulum, Zenker, and don't try to write everything. It's not possible to write everything. I'll go a little fast also. I have to cover more topic in 1.5 hour. So, and you will get the video also, so you can see again and make the note later on. So I was saying Zenker, Webb's and ring, achalasia and cancer. These are the 4 major condition causing dysphagia. And out of these 4, I can assure you, you'll get one MCQ. Definitely you'll get one MCQ, either from esophageal cancer or achalasia or Webb's and ring or Zenker. So Zenker basically is a condition which is like this is the cervical esophagus. This muscle is thyropharyngeus shown by green color and this is cricopharyngeus shown by blue color. So we have 2 muscles. So I'll not write everything, it's just a revision and I'm sure you know all this. So green oblique muscle is cricopharyngeus and blue horizontal muscle are cricopharyngeus. So green is thyropharyngeus, sorry. This red area is a weak area called Killian's dehiscence, K-I-L-L-I-A-N, Killian's triangle, Killian's dehiscence, and this is the upper esophageal sphincter. And if which muscle is this? Cricopharyngeus. So if the sphincter fails to relax, when there is more of acetylcholine and less of nitric oxide, acetylcholine more, nitric oxide less, then always there is a imbalance in the spasm. It fails to relax. And here, cricopharyngeus tone is high, pressure is more, there is a weak area, and we have a diverticulum coming out from here. So this is called Zenker. Zenker is basically, Dr. Sumer has joined. Welcome, Dr. Sumer. So first of all, Zenker is a acquired diverticulum. Congenital diverticulum, most important is Mickel's, which is an important topic in MBBS. Acquired diverticulum in GIT, most important is diverticulosis in colon. This is not as common as colonic diverticulosis, but MCQ wise, I'll say it is more important than colonic diverticulosis. So it's an acquired diverticulum coming out through Killian's dehiscence. I explained to you what's Killian's dehiscence. This triangular weak area between thyropharyngeus and cricopharyngeus. And here pulsion means there's a pressure from inside, high pressure, rather than pull from outside, it's a pressure from inside. And I'll repeat, acetylcholine more, nitric oxide less. That is the main problem here. Common in old males. Presence with regurgitation and intermittent word is important here, dysphagia. So whenever you have dysphagia in the neck, upper area, think of three conditions. First is Zenker, second is Plummer-Vinson syndrome, and third is cancer. Cancer in the upper esophagus is relatively rare, but still we do come across such cases. Most common site is middle esophagus for cancer. So regurgitation of old food and intermittent dysphagia. Now this is one X-ray which all of you must identify. In esophagus, the X-rays you have to identify are hiatus hernia, corkscrew appearance, Zenker, and achalasia cardia. So bird beak sign, I'll show you X-ray. So bird beak sign, achalasia cardia, that's bird beak sign, Zenker, hiatus hernia, and DES, corkscrew appearance. These four X-rays you must identify. I'm sure we have to know many more X-rays, but in esophagus these four are very important. So there's a low risk of cancer. Barium swallow is investigation of choice, where you have a kind of outpouching like this, and this one X-ray you have to identify. Treatment is diverticulectomy and cricopharyngomyotomy. This is the treatment of choice. We do have other options like Botox, botulinum toxin injection, diverticulopexy, but this is the main. Most important step is cricopharyngomyotomy. This is the most important step in the surgery. So you have to remove the diverticulum and cut the muscle, cricopharyngeal muscle, reducing the tone so that the pressure is gone. And second treatment option is Dolman's. Dolman is an endoscopic procedure. So salient points of Zenker are common in old male. Patient will come with regurgitation of old food and dysphagia in the neck. It's an acquired pulsion diverticulum, protrusion from Killian's dehiscence, low risk of cancer is there. Barium swallow is the investigation of choice. Now the second condition where we have dysphagia in the neck is esophageal web, called Plummer-Vinson syndrome, or it's also called Patterson-Brown-Kelly syndrome. So Plummer-Vinson or Patterson-Brown-Kelly syndrome. And you can see here, first point is this is a asymmetrical. In this diagram, it's more or less symmetrical. It's not a good diagram. This one is a classical web, where you see only web on the anterior wall. Here, arrow is showing, red arrow is showing. So only on the anterior wall. Very rarely you have web from both the walls. More often it's from the anterior wall. And this is another X-ray that can be shown to you, but possibility are less. Remote possibility, you may get a X-ray of Plummer-Vinson syndrome as well. But here the dysphagia is in the neck. Patient will be female, somewhat in 40s and 50s, with iron deficiency anemia. No, Zenker is not a true diverticulum. True diverticulum, this question is from Priya. True diverticulum are usually congenital, having all the layers. So Zenker is not a true, it's an acquired diverticulum. Meikle's is a true diverticulum. Okay? So it's false. So I was saying, if you are having a question, somewhat female between 40 and 60 years, and having koilonychia, glossitis, cheilosis, dyspnea on exertion, or any feature of anemia with dysphagia in the neck, this should be the first difference. Now you will get more clinical question. So iron deficiency anemia feature plus dysphagia in the neck, think of this condition. So this is a asymmetrical web, number one. Number two, associated with iron deficiency anemia. Post-cricoid, it's at the level of cricopharynx, cervical esophagus. Bile cancer risk is also there, around 2 to 3%. Again, investigation of choice is barium swallow. And I have shown you already the picture here. These are the barium swallow here, here, and here. In this picture also we can see a web in the cervical esophagus, but here it's more of a symmetrical kind of appearance, which is not a classical picture of Plummer-Vinson. This is asymmetrical. Okay, and treatment is balloon dilatation. Now the third condition causing dysphagia is Schatzky ring. It's also called B ring. Yeah, DK Shah, I agree with you. This is not question and answer session, so it's better you ask the question at the end. Already I have very little time, so I cannot waste time in answering a question. So Schatzky ring is a B ring. You see, This is a small hiatus hernia, sliding hiatus hernia. Schatzki ring we get here at Z line. Plummer-Vinson syndrome, the dysphagia would be kind of a mild dysphagia, persistent dysphagia, not intermittent dysphagia. So above this we have a ring called A ring, but A ring is irrelevant. It will not cause dysphagia. It is sometimes more, sometimes less. It's an incidental finding, asymptomatic. It's more of due to spasm. And here this is the C ring, which is caused by diaphragm. So neither the A ring is important nor the C ring is clinically important. Only B ring is important, which is seen at Z line. Z line is what? Squamocolumnar. Please understand, Z line is little higher than GE junction. So if I say Schatzki ring is at GE junction, in Viva in theory nobody would mind, you'll get full marks. But remember, in MCQ this is a wrong statement. It is not at GE junction, it is above GE junction at Z line. So this is a number 1 symmetrical, number 2 submucosal. We had a question on Schatzki ring in PGI in 2016. Both of these word sentences were part of the option here. Anyone having blast screen, just log out and log in again. I think the problem will be resolved. Just log out and log in. So I was saying symmetrical and submucosal. Both these points were there in the question of PGI. So unlike Plummer-Vinson, it is Plummer-Vinson asymmetrical, mucosal, it's submucosal, symmetrical, and at the lower esophagus here. And this is at Z line, caused by GERD associated with sliding hiatus hernia. Again, investigation of choice is barium swallow, and balloon dilatation is the treatment of choice. Don't excise the ring. I can do endoscopy, I can excise the ring, but that invariably leads to stricture. So endoscopic excision is not the treatment here. That will lead to stricture. Treatment is balloon dilatation. Okay. So that's another minor topic. You do have some questions on this topic. And this is, so 2 conditions causing dysphagia we have covered. One is rather 3. Plummer-Vinson syndrome, Schatzki ring, and Zenker. Now tracheoesophageal fistula is another not very favorite but frequently asked topic, TEF. Incidence around 1 in 3,000 to 4,000. Now all these lines are kind of MCQ. Most common type is this type, where the proximal end is closed and distal end is having a fistula, and this is called type C. And this is around 85%, se bhi zyada, more than 85%. So most common type is type C, proximal atrasia, proximal end is closed. Type A and B, A is the second most common. A is when the proximal end, A is atrasia, no fistula anywhere, pure atrasia, and B is proximal fistula. In these 2 conditions, we will get gastrous abdomen. So whenever you pass a nasogastric tube, Rice tube, infant feeding tube, and you find coiling of tube here in X-ray, this is classical tracheoesophageal fistula. But at the same time, if you have gasless abdomen, no gas, then this is type A or type B. So gas also you have to see in the abdomen, like this is a classical TEF where we have lots of air in the abdomen. But gasless abdomen would be type A or type B. Okay, remember this point. So type C is the most common type where we have proximal atrasia and distal fistula. A and B will have gastrous abdomen. The child will have 2 features. Number 1, he is not able to swallow. So drooling of saliva, and whenever he is fed, he will have aspiration, choking. So continuous saliva drooling, excessive saliva drooling out, and whenever he is fed, whenever you give milk to the child, he will have aspiration and choking. This is the classical presentation, except for H type where he can swallow. There is no drooling. All other type, so the question will be a low birth weight child normally having continuous drooling of saliva, and whenever he is given milk, mother tries to feed the child, he gets aspiration. This is a classical picture of TEF. You'll get a question like this. And first thing we do, pass an nasogastric tube and take a X-ray. And you can see the picture here. This is another X-ray that you must identify. You will find lots of air in the abdomen like this. This is the classical presentation. If there's no air, then it's type A or B, which is rare. A is second most common, around 6%. Yeah, you don't get coiling always. Like here you see it's just getting stuck here. So coiling is not a classical feature here. It will depend on the stiffness of the tube you are using. Normally we use little soft tube, so it gets coiled up. If I am using a stiff tube, it may not get coiled up. It may only get stuck here at the upper esophagus at 10 centimeter. So you can see here at 10 centimeter the tube will stop, either gets coiled up or it stops. For H-type tracheobronchoscopy is the most accurate. This is a question of aims. So upper G endoscopy is not diagnostic in H-type. Rather, tracheobronchoscopy is the most accurate investigation. And safest contrast is iohexol. So the contrast should be water soluble and low osmolar. So iohexol is considered safest. The treatment should be thoracotomy, posterolateral left thoracotomy. Sorry, right. I'll tell you one clinical point. Whenever we have to go to lower esophagus, this area in any condition, then we go from the left side. Then we do left thoracotomy. And whenever we have to go upper two-thirds of esophagus, then we go from the right side. This is a general principle. If the anatomy of aorta and heart is normal, this is what we follow. This is a rule. But if the vessel is reversed, so if the vessel is reversed, then my incision also gets reversed. So from the right side we go for upper two-thirds approach whenever we have to operate anything. From the left side we go when we have to operate at the lower one-third of esophagus. So here we have to go somewhat higher, somewhat in this area. That is why we go from the right side. Generally we prefer fourth intercostal space. We have two approaches, transpleural and retropleural, which I think is not relevant for you, so I'll leave that point. So you have to do thoracotomy, you have to ligate the fistula and do anastomosis. Now 2 points which might become insecure, but one has already been asked. First point, if the child is low birth weight, like is not fit for general anesthesia or thoracotomy, then you can do temporary feeding gastrostomy. Just to feed the child, keep the stomach decompressed, there's no regurgitation of milk and food into the lung, and you can feed the child through the tube. So for a low birth weight child, you can go for feeding gastrostomy. Very sick child who is not fit for surgery. This was a question in All India in the past. And second, in name of surgery, for pure atresia, suppose the gap is significant, upper and lower gap, the gap is significant, we cannot bring both the ends together, pure atresia, so anastomosis is not possible. Then we do a stage procedure called Fokker procedure, F-O-K-E-R. This question has not been asked, they might ask this question. So Fokker operation, F-O-K-E-R, is a surgery for TEF, but not a regular surgery. It's only when the gap is significant. Pure atresia with significant gap. Okay? So this is about, yes, Ayush, you are correct, it's Fokker. Now the next topic of esophagus is Boerhaave syndrome. These are some important topic, minor topic, which all of you must know. Boerhaave syndrome is a spontaneous rupture of lower esophagus. So this is the esophagus. Let's say this is the esophagus. Now somewhat lower at the left side there is a spontaneous rupture. And the reason is very high pressure of the stomach at the time of vomiting with closed cricopharynx. This sphincter is closed, so nothing comes out. Pressure is very high, stomach is contracting, and it simply ruptures at the left. 95% cases ruptures on the left side. So we generally say left lower esophagus. Rarely in 3-4% it can be on the right side as well. So Boerhaave is a barotrauma. So Boerhaave is a barotrauma, like high pressure, lower esophagus rupture, left side, vomiting against closed glottis. So sphincter is closed, pressure is high, and there is a rupture, and it presents with Meckler's triad. Meckler's triad is first vomiting or retching, followed by retrosternal pain and surgical emphysema. That is air in subcutaneous plane. Air in subcutaneous, which I can see on X-ray also. X-ray can show air in pneumomediastinum. No, Donald Modi, someone you are repeatedly asking multinodular goiter and Plummer-Vinson. I don't think there's any correlation between multinodular goiter and Plummer-Vinson syndrome. No correlation. They both are different. It has a correlation with iron deficiency anemia, not multinodular goiter. So this is called Mechler triad, vomiting, pain and surgical emphysema. Hamann's crunch is a clinical sign. This is not a sign for Boerhaave per se. This is a sign of air in mediastinum, and this is a auscultation sign. When you auscultate mediastinum, we don't auscultate from here, there's sternum, we auscultate from interscapular space. So when you auscultate from the back, you auscultate mediastinum, with the heartbeat, you hear the crunch of air. Air crunch is audible. That's called Hamann's crunch. So this sign of pneumomediastinum is Hamann's crunch, and this is auscultation sign where air crunch is audible with heartbeat. X-ray will show few signs, and I'll show you these signs, but I'm sure it won't be asked. Theoretically they might ask, but they'll not show a picture to identify. This is called continuous diaphragm sign, where you can see the air connecting both the diaphragm. Then we have Neclario V sign. This air seen here is called Neclario V sign, V-shaped air in the mediastinum. Then we have a Spinnaker's sign, which is due to thymus. So this is the thymus, this red area. This is Spinnaker, thymus, the red part. And the red, what I showed here, which is shown by white color in the X-ray. This is the Spinnaker sign, and the blue part is the angel wing sign, which is air. This is air, and this is thymus. So red area is Spinnaker sign, and black area, which I showed by blue color, is the angel wing sign. CT scan is very good investigation to see air. So all these signs you may get in pneumomediastinum. Now here I'll emphasize one point. Contrast study is investigation of choice for leak. For inflammation, we will order CECT. It's most sensitive. That's why, and CT is easily available nowadays. That is why most of books, including Love and Bailey, have written that Boerhaave CT scan should be ordered. I don't deny this. This is a correct statement. But Mangots have clearly mentioned for leak, to see the leak, the site, contrast still the best. So if I say in Boerhaave, what is the best investigation for leak? Still the answer is barium, contrast, not barium, iohexol followed by barium, contrast. So there shouldn't be any controversy. For inflammation, for pneumomediastinum, for to see local changes, CT is best. But for leak, contrast is best. Okay? So still contrast has very important role here. And immediate surgery is the treatment here. Now here I'll go from left side, left thoracotomy. Why left? Because we have to go to lower esophagus. So left posterolateral thoracotomy and do immediate repair. Okay? Now this is a bird beak sign of achalasia cardia. This is another X-ray which you must identify. With a gap of 3-4 years we get this X-ray. Probably last year it was asked, or probably last year. So this year most likely they'll not ask this. It was asked very recently, but you must identify bird beak sign. Bird beak sign of achalasia. The reason for achalasia is non-relaxation of LES due to absence of inhibitory fibers of Auerbach plexus, also called Meintrich plexus. So I'm repeating, only inhibitory fibers are absent, not the complete ganglion, unlike Hirschsprung disease. In Hirschsprung, the complete ganglion is absent. Here only inhibitory ganglions are absent and presents with dysphagia in young age, 20 to 40 years. So this is a classical bird beak sign of achalasia cardia. Heller's myotomy is the treatment. Another catch point here, now books do say that Heller's myotomy with Dor fundoplication. Please understand, this Dor fundoplication is not the part of surgery for achalasia. This is to prevent GERD. The achalasia cardia Heller's myotomy is very often associated with reflux. So whenever I say Dor fundoplication is done along with this myotomy, understand fundoplication is to prevent GRD, which is a complication of surgery, not to treat achalasia. Fundoplication has nothing to do with achalasia. Fundoplication is done for GRD and for hiatus hernia. Another new surgery is POEM. This is done for long segment. Yeah, rat tail also you may get. Anubhav, rat tail means the narrowed segment is long. So rat tail also you get in achalasia, but rat tail more often we get in cancer. So rat tail, if it is irregular, it is cancer. If it is smooth, it's achalasia. But achalasia generally is a short segment disease. A long segment will cause rat tail, and for long segment, this is the treatment that we do get. So POEM, per oral endoscopic myotomy, is done for long segment, and we do have a Chicago classification. So POEM is preferred for, according to Chicago classification, type 3 achalasia. For type 3, this is preferred. Type 2 and 1 are treated by myotomy or botulinum toxin or the balloon dilatation, etc. But for 3, POEM is better. Type 2 has best result. So achalasia, Chicago classification. Type 2 is more common, it has best result. And for type 3, POEM is better. Okay. Now, salient features about esophageal cancer. First, a controversy. What is the most common site for esophageal cancer? Most common site since decade is middle 1/3 without any controversy. And most common type is squamous cell cancer. Okay. The books which say lower 1/3 is more common is only for white males. White males, not for all over world, not for India, white males. And here we have adenocarcinoma. Lower 1/3 adenocarcinoma. Laparoscopic myotomy is preferred over laparotomy. So Sandeepan, laparoscopy is preferred over laparotomy, but even laparotomy and myotomy can also be done. Both give same results. The morbidity of laparoscopy is little better, less I mean, so that's why we prefer laparoscopy. But it's same, so result wise same. DOR is a anterior wrap. DOR is anterior. Anterior wraps are DOR, DOR, Watson, these are anterior, and Belsay. So GERD I have not included in this discussion. Anterior wrap are Belsay, DOR, and Watson. Okay, this is a part of fundoplication. And posterior wraps are Nissens and Toupet. DOR is anterior. Belsay is 270 degree. DOR is 180 degree. Watson is less than 180, around 120. Nissens is 370 degree. And Toupet also between 180 to 270 degree. So that's a separate topic that we cannot cover here. We don't have that much time. Right? So because of your question, I've answered this. Okay. So for lower 1/3 white males adenocarcinoma, then the lower 1/3. If I say most common cell cancer for adenocarcinoma, my white male, then answer would be lower 1/3. Otherwise, answer always is middle 1/3 and squamous cell cancer. So that's the point number 1. Strongest association, and my advice to all of you, please remember the risk factor from esophageal cancer to anal canal cancer, or rather oral cavity also. So oral cavity, esophagus, stomach, liver, gallbladder, pancreas, colorectal cancer. And my observation was in past, every year we used to have one question from cause of GIT cancer. Of late now, NICET, a new trend has come up, so now I cannot say that it's always asked, but in the past it was always asked one question from GIT cancer, one question every year from cause. So remember, and acute pancreatitis causes as well. So remember the cause of all cancers of GIT plus pancreatitis causes. You can take my word, if you give 3 or 4 exams in a year, in at least 1 or 2 exams you will get 1 question from this. So it's very important. So strongest association for squamous cell cancer is with tylosis, where the risk is almost 90%, and for adenocarcinoma it's Barrett's, where the risk is almost 40 times higher. So for squamous cell, tylosis, which is autosomal dominant condition, tylosis with hyperkeratosis of palm and sole, here the risk is strongest risk for squamous cell cancer, and for adenocarcinoma, Barrett's. For screening, which is not done in India, chromoendoscopy is the modality. This is a question in all India. Methylene blue is used for adeno, for columnar, and iodine for squamous cell. Iodine acetate, what you use for colposcopy, same you use here, squamous cell, same cell. So iodine for squamous and methylene blue for columnar. First investigation for any esophageal pathology should be endoscopy. Endoscopy. But if the patient having very severe dysphagia, he cannot even swallow the liquid, or dysphagia in the neck, then we should order barium swallow first. Otherwise, we might perforate the esophagus. So in the question, if the question says patient having very severe dysphagia, he is not able to swallow even the liquids, or he is having dysphagia in the neck, then my first investigation should be barium swallow. Otherwise, my investigation and investigation of choice is endoscopy. This is investigation of choice as well. So for any patient with dysphagia, I'll order endoscopy. For staging, PET-CT is best, and for T or N stage, locoregional endoscopic ultrasound is best, and for metastasis, 18 FDG PET scan is best. All 3 lines you have to, if you remember these 4 lines, you can answer all question of investigation for esophagus, stomach and colon. What will order first? Endoscopy and biopsy. What is best for staging? PET-CT. If PET-CT is not an option, then I'll say CCT. If PET is not an option, then say CCT for staging. But PET-CT, because it's being done for last 15 years, it will be option. So PET-CT is best for staging. And another MCQ can be, PET-CT is not equally accurate for all. It is best for metastasis followed by node followed by T, sensitivity wise, accuracy wise. For metastasis, more than 90% accurate. For node, 85-90%, and for T, around 75%. So for depth, it is not a good investigation, but overall, it is best. For all 3, it is best. For depth and node, endoscopic ultrasound called loco-regional stage, which is MCQ again, and only to see metastasis, 18 FDG PET scan. Another MCQ, 18 FDG has a half-life of 110 minutes. Now, next important question, very minor but very important question, CHPS, congenital hypertrophic pyloric stenosis. Incidence 3 per 1,000, common in first-born male child. Erythromycin increases the risk of CHPS. If the child is given erythromycin after birth, within 1 week, the risk is more. Patient presents with non-bilious projectile vomiting. All words are important. Non-bilious projectile vomiting between 3 to 8 weeks after birth. He is absolutely normal antenatally, postnatally. Around 4th week, 5th week, he'll have vomiting. Projectile, non-bilious. And he is always hungry. On examination, you will find a olive-shaped lump in the epigastrium and left to right peristalsis. Left to right. Now you are getting questions on videos as well. And again, I can ensure you, whenever they'll ask a video on clinical examination, this will be one of the very first video in AIMS. Now you don't have AIMS separate exam. In the exam you will get. Why? Because it's very common in India. In emergency OPD and pediatric surgery, very often we see a parent bringing child with a prominent epigastric olive-shaped lump and a peristaltic, wave going from here to here. So this is very common in India, very important topic. So this will be one of the very first videos you will get in clinical examination. Whenever they start asking video on examination, this will be one of the very first videos you will get. So left to right peristalsis and olive-shaped lump in the epigastrium. Investigation wise, ultrasound is the investigation of choice. Length of pylorus 16 and thickness more than 4 and the total width more than 14. This figure I have not written more than 14 because that's not very important. Total width 14, thickness 4 and length 16. So target sign, what you see here is called antral nipple sign and cervix sign. These are the sign on ultrasound. This is another target sign here. And this is the barium meal where the pylorus gets stretched, gets compressed and stretched, giving a string sign and a mushroom sign. Duodenal bulb and stretched pylorus. So this is the string sign and this is a mushroom sign. Sometimes we do have two string here, then this is called double track sign. So string sign, mushroom sign, which is the diagram itself, the arrow is showing mushroom-like picture and a string sign, caterpillar sign, these are some signs. Now this is one of the very, very important point. All of you must remember this. Electrolyte abnormality here is hypochloremic, hypokalemic metabolic alkalosis and paradoxical aciduria. This paradoxical aciduria is due to aldosterone. This also you remember. So aldosterone, paradoxical aciduria. And one more thing. Sodium gets corrected. Hyponatremia we don't get. That is why I have not written hyponatremia here. So hypochloremic, hypokalemic, metabolic alkalosis plus acid. When the blood is alkaline, urine should be alkaline. Why hydrogen is excreted from kidney in spite of alkalosis in blood? Because of aldosterone. Aldosterone has a, what is the function of aldosterone? Produced by zona glomerulosa of adrenal cortex. It absorbs sodium and water, excretes potassium and hydrogen. So this excretes hydrogen in urine, causing paradoxical aciduria. Now, resuscitation fluid is fluid of choice is N/2 saline. I'll tell you another catch point here. Whenever kidney does not have concentrating capacity, like a patient of CRF, what fluid I should give? Don't overload sodium, N/2 saline. After transplant, kidney has not yet regained its total function. What is the fluid of choice? N/2 saline. So here also, before 1 year, the neonatal kidney or child kidney is not mature enough to, does not have proper concentrating capacity. So again we give N/2 saline. But here I'll add potassium. In CRF I'll not give potassium, but here I'll give potassium because the child is having hypokalemia. So N/2 saline. Why not ringer lactate? Why ringer lactate? And this is a catch point, clinical point. Why not ringer lactate? Ringer lactate we can give, but why not fluid of choice? Saline has sodium 154 milliequivalent per liter. And same chloride. Ringer has sodium 130 milliequivalent per liter. So firstly, we have less sodium here. Secondly, this lactate goes to liver and gets converted to bicarbonate. So what it does, it causes alkalosis. That's why in trauma, in burn, in shock, we have metabolic acidosis. So we prefer ringer lactate because it will counter the acidosis. Here already we have alkalosis. That's why ringer lactate will promote the alkalosis, will increase. That's why ringer lactate is not, it can be given. I'm not saying it shouldn't be given, but yeah, it's not fluid of choice. Fluid of choice is N/2 saline with dextrose and potassium. Okay. Now another important point here, which will become one of the MCQ line. This is a non-surgical emergency. I'm repeating. This is emergency, but not a surgical, non-surgical emergency. What I mean by this, we will operate only after correcting the medical problem. What is the medical problem? Dehydration and alkalosis. So give fluid when the urine output is more than 1 ml per kg per hour and bicarbonate is less than 30, only then we will operate. So you have to wait for a day, 2, 3 days, doesn't matter. You wait. Correct electrolyte imbalance, correct dehydration. These are the parameters you have to achieve. More than 1 ml per kg per hour, bicarbonate less than 30, only then you operate. And what is the surgery that you do? Ramstead pyloroplasty. Not to be confused by pyloroplasty. Pyloroplasty is a totally, yeah, in adults also it gets converted. I hope I guess you're asking question, Prerna, about ringer lactate. In adults also you have same physiology. It goes to liver, gets converted to bicarbonate. Yeah, this is a Sandeepan and practical question whether 5% dextrose or 2.5% dextrose. Well, if you read your book, it says 5% dextrose in the books. But in India, we don't have N/2 saline with 5% dextrose. It's available in West. In India, what we do, we take normal saline 9% and combine with 5% dextrose in equal amount. So naturally, this becomes 0.45% and this becomes 2.5%. So in India, we are using 0.45% saline plus 2.5% dextrose. That's why some faculty will say 2.5. But you can use 5%, no problem, okay? I have lots of topic left, so I cannot go this slow and I cannot keep on answering a question. So please bear with me and don't make notes because I'll go a little fast now. Just listen, I'll try to make the concept clear. You can make notes later on by seeing the video. So as I said, pyloramyotomy should not be confused with pyloroplasty. Pyloroplasty is totally different. That's done in adults. And medical treatment is atropine, but side effect more, results not good. So pyloramyotomy is the treatment of choice. Now gastric cancer, another controversy. What is the commonest site? Commonest site since ages was antrum of the stomach. So in India and third world country, it is still the most common site. Still, in practice, if you ask a surgeon, he'll say I get more cases of antrum than other areas. But this is not the right MCQ answer because the cancer has started shifting proximally. And the proximal gastric cancer has become the most common site today. So if I say what is the most common site, the answer is proximal gastric cancer. And we have a new term, GE junction cancer. This is the most common site in West. In West, the most common site is GE junction cancer. For GE junction cancer, we have so most common site is proximal gastric cancer, followed by fundus. In India, antrum. For GE junction cancer, we have a Sievert classification, which is the old MCQ. This was a question asked in All India, that Sievert classification is used for what? It's used for GE junction cancer. And this includes 13 per centimeter length, 13 centimeter. 5 lower esophagus, 5 upper stomach and 5 in between. So for 13 centimeter of the area, we say Sievert classification, that's a GE junction cancer, 13 centimeter. This figure you have to remember. So 5 centimeter esophagus plus 3 centimeter in between GE junction, 5 centimeter stomach, total 13 centimeter, 1-3. Now the new drugs approved, the important topic will not change. New drugs that has been approved, one is the trastuzumab, and cardia is not a separate site now. Harshita, cardia is not a separate site. Cardia is included in GE junction. That is why I said GE junction has become the most common site. So cardia today is a part of GE junction cancer. It comes under Sievert classification. Okay? So if someone has told you cardia is the most common site, he is absolutely correct. But today cardia is not considered a separate site. It has been included in GE junction cancer today, which is a part of Sievert classification. Okay? So trastuzumab is only for HER2 new positive. Ramucirumab is another drug approved for VEGF positive. And pembrolizumab, this is somewhat important, is for PD-L1 recurrent gastric cancer. So these are the three new drugs which have been approved. S1 chemotherapy was approved in 2019 by FDA. This is a oral 5-FU substitute having tegafur as the main ingredient. This is only for advanced gastric cancer. S1 chemotherapy is giving good result after metastasis or advanced gastric cancer. This can become a question. S1 chemotherapy is used for what? So S1 chemotherapy is basically used for gastric cancer which are advanced or as a neoadjuvant therapy or after metastasis. Okay, this is an oral fluoropyrimidine derivative and the main ingredient is tegafur. Now coming to surgery for gastric cancer, remember only 2 lines. For distal gastric cancer, we do subtotal radical gastrectomy. For distal gastric cancer, with a 5 centimeter margin. Margin should be 5 centimeter. There is a diffuse variety. For that we use 8 centimeter margin. So either 8, if you have asked a MCQ, then answer is 5 centimeter, but for diffuse variety we take 8 centimeter. So for distal gastric cancer we do subtotal radical gastrectomy and Billroth 2 reconstruction. Billroth 2. For proximal gastric cancer, total gastrectomy is done radical. And here we do Roux and Y esophagojejunostomy. It's written here. So you see, for distal gastric cancer, subtotal gastrectomy with Billroth 2 reconstruction. For proximal gastric cancer, total gastrectomy and Roux and Y esophagojejunostomy. Esophagojejunostomy. And the margin is 5 centimeter, but for diffuse variety 8 centimeter. And recommendation is D2 gastrectomy. This is another question. Minimum number of nodes should be 15. The level should be 3, which should go up to celiac trunk lymph node, and Japanese station 11. This is the stomach. This is the celiac trunk with all the vessels. So when you go up to the celiac trunk node up to this area, that's Japanese station 11 or level 3. So all 3 points you have to remember, number of node more than 15, level 3 till celiac trunk, and Japanese station 11. Some signs of pneumoperitoneum, this is a very frequently asked question. Investigation of choice. This was a direct question in JIPMA a few years back. Otherwise, remember, for pneumoperitoneum, investigation of choice is X-ray chest, erect view. Chest, not abdomen. I'm sure some of you are under the impression that we have to see gas below diaphragm, so we should order abdomen. No, X-ray chest. Because it's more accurate, it can detect as little as 1 ml of free air below diaphragm. And this is one X-ray, which is one of the very, very important X-ray in abdomen. You must identify this. So this is X-ray. This is not X-ray gas below abdomen. This is fundal gas shadow, stomach fundal gas shadow. So don't look at the left side, only on the right side. And this is another picture of gas below diaphragm. So gas below diaphragm you must identify. This is the investigation of choice. But if X-ray chest is not possible, then in abdomen, left lateral decubitus is the best view to see air. This is the left lateral decubitus. This can detect 2 ml of air. You can see air outside the colon, ascending colon. So left lateral decubitus is most accurate view to see free air in abdomen in abdominal X-rays. Otherwise, X-ray chest. Other signs that you must identify, this is called cupola sign, just like continuous diaphragm sign, air connecting both diaphragm. And this is called Wriggler sign, where we can see the bowel wall. All these white lines are bowel wall, and that is seen between the two arrowheads. You can see the white lines. These are the bowel. This is another sign that they can ask you in pneumoperitoneum. Rest of sign they'll not ask. But gas below diaphragm and Wriggler sign, these two signs you must identify. What is Wriggler sign? Wriggler sign is, I can see the bowel wall as a white line because air is in the lumen, air is outside. So on both the sides we have air, and I can see the bowel wall in between. So if I zoom the area, I'm sure you can see all the bowel wall here. So bowel wall is visible because air is outside and lumen. This is a Wriggler sign, and this is another important sign you must identify. Doge cap sign is air in Morrison pouch, another sign of pneumoperitoneum. Falciform ligament sign or silver sign is, you can see the falciform ligament in X-ray or in CT. That's another sign of pneumoperitoneum. An inverted V-shaped sign, this sign here, is another sign of pneumoperitoneum, seen due to umbilical artery in children and inferior epigastric artery in adults. So these are some signs of pneumoperitoneum. Out of these 5-6 signs, 2 signs you must identify. First is gas below diaphragm, right diaphragm. Second is Wriggler sign. Only 2 are important for you in X-ray. Now, Chilaiditi syndrome is actually air below diaphragm, but that's not a free air. This is in the bowel loop. This is called pneumoperitoneum and pseudopneumoperitoneum, and this is basically interposition of bowel between liver and diaphragm. So this is a bowel loop. Like here, it's a colon. Now, coming to functional anatomy of liver, this is our again favorite topic. You see, liver is divided into right and left lobe in anatomy by falciform ligament, not in functional anatomy. Here it is divided by Cantley's line, this line. Falciform ligament is here. So Cantley's line, you can see this is the Cantley's line here, dividing liver into right and left lobe. And Cantley's line is running from inferior vena cava to medial edge of gallbladder fossa. This is the Cantley's line. It has middle hepatic vein. So the liver has 3 hepatic vein, right, middle and left. These are the vertical line, and portal vein goes like this. Like this is the portal vein having bile duct and hepatic artery. So liver gets its 8 segment by hepatic vein and portal vein. Portal vein will be accompanied by hepatic artery and bile duct. So this classification was given by Coinod, it's pronounced Cuneo, in 1957. Still we follow this. So Cantley's line is a line coming from IVC to medial edge of gallbladder fossa. It has middle hepatic vein, and you can see 3 hepatic vein. First, second, right, middle, left. Right hepatic vein will directly go into the IVC. Left and middle, first they fuse and become one. Like this is the IVC. Right will go like this. Left and middle will fuse and become one, and then they drain into IVC. So middle hepatic vein, left hepatic vein, they become one. In almost 95%, they fuse and become one. Then they go into the IVC. This information is required when we do renal transplant, liver transplant. That's some technical point here. So here you can see the 8 segment, and the best way to remember the segment is basically start from 2. Forget 1. When is posterior, we'll discuss later on. Start from 2 and go clockwise. 2, 3, 4, 5, 6, 7, 8. This is left and this is right. Falciform ligament is here. This is falciform ligament. So anatomically this part should come into right lobe, but physiologically, physiological anatomy, it is, or other surgical anatomy, functional anatomy, this is left lobe. So this whole thing is left and this is right. Now these 4 are sector. This is the lateral sector. This is the medial sector, 4A, 4B. This is the anterior sector, 8 and 5, and this is the posterior sector, 6 and 7. So we have 4 sectors in the liver, left lobe having lateral and medial sector, right lobe having anterior posterior sector. These vertical lines represent what? These vertical lines represent hepatic vein. So if I am doing left hepatectomy, I am removing 2, 3, 4 segment. If I am doing right hepatectomy, I am removing 5, 6, 7, 8. But we can remove sectors also. So you see here, starting from 2, 3, 4, 5, 6, 7, 8. 4 has a 4A and 4B. Upper one is 4A, lower one is 4B. So this is lateral, this is medial, this is anterior, this is posterior. So if I remove only 2 and 3 segment, this is left lateral hepatectomy. If I remove 4, left medial hepatectomy. 5 and 8, this is right anterior. 6 and 7, right posterior. So these are the important terminologies you have to know. I'll tell you what questions are they ask in functional anatomy of liver. So hemiliver is Cantley's line. Remember, hemiliver is Cantley's line. These are 2 hemiliver. So this is the Cantley's line, not falciform ligament. Falciform ligament is here. So Cantley's line divides liver into right and left lobe, coming from IVC to medial edge of gallbladder fossa. This whole pink area is left. Anatomically, only this part is left. But functionally, or this whole is left, and this blue area is right. So left is lateral and medial sectors, and right has anterior, posterior. So lateral has 2 and 3, anterior, medial is 4A, 4B, anterior 5 and 8, posterior 6 and 7. So you can see right hemiliver, Cantley's line divides liver into right and left, coming from IVC to gallbladder fossa. It's divided into anterior and posterior sector, and left is divided into medial and lateral sector. So you can see again here, lateral 2 and 3, anterior 4A, 4B, and lateral medial 4A, 4B, anterior 5 and 8 and posterior 6, 7. So now you can understand the terminology, like if you see here, if I remove this blue area, this is important. Portal vein is going like this. Portal vein is going like this. Like this. This is the portal vein. This will be accompanied by hepatic artery and bile duct. Bile duct and hepatic artery. So if I remove the blue area, this is the right hepatectomy, 5, 6, 7, 8. If I remove the blue area in this diagram, this is right, this is left. But if I remove along with right hepatectomy segment 4 also, then this becomes right extended hepatectomy. And along with the left lobe, if I remove 5 and 8, this becomes left extended hepatectomy. So these 4 terminologies you should know: right hepatectomy, left hepatectomy, right extended, left. They do ask this question. So right is 5, 6, 7, 8, left is 2, 3, 4. Right extended means this one. Along with 5, 6, 7, 8, 4 also. And left extended means this one. 2, 3, 4 along with 5 and 8. Okay, so and if I remove only this 2 and 3, then I am doing left lateral hepatectomy. This is what we do in liver transplant. In liver transplant, when you do a split liver transplant, you only take 2 and 3, and that's left lateral hepatectomy. Okay, and so this is the lateral, this is medial, this is anterior, this is posterior. What about segment 1? Segment 1 is behind 4A here. This is segment 1. So segment 1 is behind 4A. Let's zoom in. This is the segment 1 here. And it is very special. It's called caudate lobe. Caudate means tail. It's like a tail. And it's a dorsal sector. It doesn't come into. Medial sector is actually lateral. How come, Mona? This is lateral. This is medial. Because you imagine that liver is on the right side, so you are saying medial is actually lateral. No. This Cantley's line is IVC. So this line is the midline, this line. So this is totally on the left side. This whole thing is on the left side. So this is lateral and this is medial. Okay. So I was saying it's called dorsal sector. Right extended means 5, 6, 7, 8 along with 4A and 4B. So dorsal sector means it's not coming under medial, lateral and anterior posterior sector. It's separate sector. And most important point, it receives supply from both the side, right and left. You can see here, right branch is giving and left is also. So it's supplied by both, and it drains into vena cava, directly into vena cava. You can see in the diagram. Rest of the sectors are draining into hepatic vein, while it drains into vena cava. That's why if we have thrombosis of hepatic vein called Budd-Chiari syndrome, segment 1 is spared. So these are the clinical questions you should remember. First, you know the terminologies, right hepatectomy, left and all these sectors and segment. Number 2, falciform ligament is here. So left lobe anatomically is different from left lobe functionally. Anatomically, segment 4 comes in right lobe, but functionally segment 4 comes in left lobe. Third, segment 1 is totally different, not involved in Budd-Chiari syndrome. It drains into vena cava. Okay. Fourth, when we have gallbladder cancer and you have to do some hepatic resection, extended cholecystectomy, like this is the liver and gallbladder is here, you have to do extended cholecystectomy with liver. Which segment will remove? 5 and 4B. So segment 5 and 4B are also removed in gallbladder cancer in extended cholecystectomy, radical. So in cancer we remove 5 and 4B. So these are some important clinical questions you should remember, right? So this is about functional anatomy of liver. Of course I cannot cover the all topics in 5-10 minutes, but important. Let's discuss quickly the benign tumors of the liver. Important salient feature. Hemangioma, you have to remember, it's the most common liver tumor. Most common. Okay? And most common liver tumor. More common in female. Now 2 points. First, giant hemangioma is more than 5 centimeter, can trap platelet and cause thrombocytopenia. This is called Kasabach-Merritt syndrome. Not liver, any hemangioma in the body. When they are giant, more than 5 centimeter, they can trap platelet, and that's called Kasabach-Merritt syndrome, thrombocytopenia. Second, CT scan and MRI both, when you give contrast or gadolinium in MRI, they accumulate peripherally initially, and that's called peripheral enhancement. So peripheral enhancement, you can see here, is a feature of hemangioma. So any liver tumor giving peripheral enhancement, you can see in CT also. These are the 2 CTs, one here showing peripheral enhancement. So this is hemangioma. Anatomically, segment 4 will come in the right lobe, anatomically. But anatomically, there is no segmentation. Segment, if I use the term segment, it means I am discussing not anatomical, I am discussing surgical or functional anatomy. So by default, it will come into the left lobe. So peripheral enhancement. So 2 points about hemangioma you have to remember are the 3-4 points. Most common benign tumor of liver, hemangioma, can cause Kasabach-Merit syndrome, thrombocytopenia, and CT scan shows peripheral enhancement. Okay. Treatment is observation or enucleation. Second benign tumor is adenoma. What are the main features of adenoma? Adenoma has a very strong association with occipit. This is one point you have to remember. All liver tumors are associated with estrogen. It has the strongest association. Number 2, it has a risk of spontaneous hemorrhage as well as cancer. So you have questions like which liver tumor is known to cause hemoperitoneuum? Adenoma. Which liver tumor is known for spontaneous rupture and bleeding? Adenoma. A young female on occipit comes with pain in abdomen, liver mass and blood in abdominal cavity. What is this? Adenoma. So adenoma has a risk of bleeding, spontaneous rupture. Number 2, cancer. It can progress to cancer as well. Because that's why this is another MCQ. This is the only liver tumor, though asymptomatic, should be removed. Very small tumor, of course 3-4 centimeter we can keep under observation. But slightly bigger, all liver tumor asymptomatic benign are kept under observation. But not adenoma. Adenoma should be excised due to the risk of cancer as well as hemorrhage. Now, we have a new classification, Bourdieu classification for adenoma. It has 4 types: inflammatory, beta-catenin mutated, HNF1 alpha mutated, and miscellaneous. Only 2 lines. Inflammatory is the most common type and it has a risk of hemorrhage. This can become one MCQ. Which type of adenoma has the highest risk of hemorrhage according to Bourdieu classification? Inflammatory. Second question is, which type of, this is the most common, inflammatory. Which type has highest risk of cancer? Beta-catenin mutated. This is common in male, especially on anabolic steroids. So beta-catenin mutated adenoma has the highest risk of cancer. Okay. Another benign tumor is focal nodular hyperplasia, and focal nodular segment 9. Okay, that's a relevant question, so I must answer segment 9. You see, there's no segment 9 today. Segment 9 has been incorporated in segment 1. So segment 1 has 3 parts: paracaval, aspergillian, and caudate process. This paracaval part of segment 1 was segment 9 earlier. So there's no segment 9 today, only 8 segment. Okay. Right. So focal nodular hyperplasia is the most common benign, second most common benign liver tumor. No risk with occipits, no risk with cancer, contains Kupffer cells. So these 2 points are important, these 2 points. So contain Kupffer cells, so give hot scan, sulfur chloride scan. Number 2, they show central scar. Liver tumor can have central, even HCC can have central scar, but 2 liver tumor, main liver tumor having central scar are, one is FNH and second is fibrolamellar cancer. Fibrolamellar cancer. In pancreas, we have central scar in serous adenoma. I'll be discussing that later on. And in kidney, central scar we get in oncocytoma, which is another important topic in urology. So central scar we get in FNH. It's benign, kept under observation unless it becomes symptomatic. So these 2 are 2 more liver tumor having central scar. So in pancreas, if you are getting central scar, it is serous adenoma. In kidney, oncocytoma. In liver, FNH more common, followed by fibrolamellar cancer. Now HCC, these are the question. For screening, we only do ultrasound. We don't do alpha fetoprotein because it's very non-specific. But for follow-up, we use ultrasound and AFP both. An investigation of choice is triple phase CT, which simply means that if there's a tumor in arterial phase, it becomes white, hyperdense. Later on, when the liver becomes white, hyperdense, by that time this tumor starts to become hypodense. So early uptake, early washout, you can see here. This is the tumor. This is the portal vein, no contrast in portal vein. So it's arterial phase. The tumor has become white. Later on, when the liver starts becoming white, hyperdense, then the tumor has become hypodense. So early uptake, early washout is very classical. It is so specific for HCC that now American Gastroenterological Association say that if you have a CT like this, early uptake, early washout, and AFP more than 300, this is HCC, you don't have to take biopsy. So it's quite a good test. Now this is another HCC. You can see early uptake here in the tumor, and when the liver becomes white, it has become hypodense. This is another classical HCC, early uptake and early washout. Here you can even see capsular enhancement also. Sometimes in HCC we do get capsular enhancement as well. The newer modality of treatment for HCC, one is Nimura technique. This can become already they have asked it once, it can become MCQ again. Nimura technique basically is done when the FLR, future liver remnant, is less than 30%. Some books say 25%, but 30 is a better figure. What I mean to say, that liver we are leaving after surgery, the volume wise is not good enough to have normal sustainability of life. You need a bigger liver volume. So what is done here, like this is the portal vein, we block the portal vein here by artificial thrombus, all the blood will go to the normal side, the liver will undergo hypertrophy, and maybe after 2 weeks or 3 weeks we can operate. So Nimura technique is basically a iatrogenic portal vein thrombus prior to resection, and it's done when the future liver remnant is less than 30 or with cirrhosis less than 40, and it's only indicated in 2 conditions. One is HCC and second is liver secondaries, no other secondaries of the liver, only colorectal cancer it's approved. So you can see here a guide wire is going here like this. A thrombus has been placed in the portal vein. Now the right lobe is undergoing atrophy because you have stopped the blood supply, and left lobe is undergoing hypertrophy. And you can see after surgery, this is the hypertrophy. Compare this with the first picture where it's concave and last one it's convex. So this is a Nimura. The same technique is, the same technique but little different name. In Nimura, this part of liver should be normal. The liver we are going to leave behind, we are leaving behind. But if already there are secondaries, this is a new thing which we have not discussed in regular batch or in DVT or anywhere. This is a new thing, so please listen carefully. If I have tumors in this area already, multiple tumors, what to do now? Now here I'll do stage procedure. First I'll operate and I will remove this tumor. Surgically I'll remove this tumor from the part which I'm going to leave behind. Then surgically I'll ligate the portal vein and rest is same. Wait for hypertrophy, operate. This procedure is called ALPPS. This is a new procedure, not yet mentioned in books. Neither I discussed this in regular batch or DVT anywhere or in test. It's a very new procedure, but they may ask this. Nimura is an old procedure. So here you see ALPPS stands for Associating Liver Partition and Portal Vein Ligation. Associating liver partition and portal vein ligation for staged hepatectomy. So what you do, already there was a cancer here. So first you operate and remove the cancer, then you ligate this portal vein and then let the liver undergo hypertrophy and operate. Same thing. But the difference between Nimura and this, first Nimura is a percutaneous technique done under ultrasound guidance or CT guidance. Number 2, in Nimura the FLR should be normal, while here the FLR already has a cancer which I operate in first step, then I surgically ligate the portal vein and do a second stage surgery. Now radio frequency ablation is another new treatment which is approved for osteoid or prostate or for arrhythmias and many other conditions. So in GIT, its indications are liver tumor less than 5 centimeter, Barrett's, watermelon stomach, bleeding, and bleeding from other mucosal tissues, mainly bleeding. And so here you pass a probe, you can see here, and then you deliver alternating current at 470 kilohertz. Alternating current at 4. The range is 350 to 500, but generally in India it's being done. We use 470 kilohertz. And we increase the temperature here. Up to above 70 degree, the tissue will get destroyed. We can go up to 120 degree. So alternating current is passed through a probe and you necrose the tissue by hyperthermia. Necrosis you achieve is up to 7 centimeter, so it is approved for 5 centimeter. For kidney, radiofrequency ablation is for 4 centimeter. For liver, it's still 5 centimeter. So radiofrequency ablation can be done. Okay. Another newer modality is TACE, transarterial chemoembolization. Now we have liver with multiple secondaries. There is a rule of 7 here for TACE, which is not mentioned in this theory part. Rule of 7 means the volume of tumor should be less than 7 centimeter together and total size should be 7. So less than 7 secondaries and volume wise, size wise less than 7 centimeter. By adding all the secondaries, it should be less than 7 centimeter. So here we embolize the branch of hepatic artery supplying the tumor. The liver will survive on the portal vein now, and not only you make tumor atrophic, this embolus is actually chemotherapy. This is called DEB. Anvesha, we don't remove all secondaries. We only remove the tumors from the FLR, which is the part of liver we are going to leave behind. Only FLR. And you can see in the diagram also, these are left behind, and you can see only these two are removed. Only FLR. So TACE, we are using drug-eluting bead. They perform two functions. First, they cause ischemia and necrosis of the tumor. Second, they work as chemotherapy. Portal vein thrombosis by malignancy and hepatic encephalopathy are contraindication for TACE. In portal vein thrombosis, we can go for TARE, transarterial radioembolization. Same thing, but I am using radio. The best advantage here, it can be used in spite of portal vein malignant thrombus. TACE cannot be used. So yttrium-90 is used as a radioembolus, having a half-life of 64 hours, high beta emission, TARE. Now, Milan criteria, they have asked two questions. Twice it has been asked. So Sandeep, this is for, yeah, Pooja, this is for you. Milan criteria, they have asked twice. We have many criteria to decide liver transplant in HCC. One very important criteria university followed in America is University of California, San Francisco, UCSF criteria, which is slightly different from Milan. But Milan is more commonly followed in Europe and it's given in your book. So in India also you have to remember only Milan, not other criteria. So Milan, which is also called Mezzafero criteria, one is tumor should be less than, and Milan should not be confused with MELD score. MELD is for not for cancer, for any liver where you go for transplant, you decide when to do transplant. This is only for cancer. Till what stage of cancer you can operate. So single should be less than 5 centimeter. Multiple tumor, then each foci should be less than 3 and number should be less than 3. And no major vascular invasion, no extrahepatic involvement. And one more point, you can write some minor types like fibrolamellar cancer, we can go. Size does not matter there. Fibrolamellar is a relatively low grade cancer. But for HCC, size should be less than 5 centimeter, number should be less than 3, and none of them should be more than 3 centimeter in size, no major vascular invasion. Now, salient features of gallbladder. You see, acute cholecystitis investigation of choice is, drugs used in DEB is mentioned here, doxorubicin, cisplatin or mitomycin C. So as I said, you'll be getting the videos, I hope, I presume, you can see all these slides later on also, so there's no need to interrupt. So acute cholecystitis is investigation of ultrasound. The problem is sometimes I get the answer HIDA scan because some books say HIDA is most accurate. No, HIDA is not investigation. For A calculus cholecystitis, again most accurate is HIDA followed by CT followed by ultrasound. So ultrasound is relatively less sensitive and accurate, but investigation of choice is always ultrasound. Whether calculus, A calculus for all. For M5C matters, CT scan is best. Okay, CT is best. When you want to see air, CT is best. Ultrasound gives champagne glass sign for emphysematous. Adenomyomatosis investigation is MRI, which gives pearl necklace sign, and rosary bead sign, pearl necklace sign. Ultrasound do give comet tail sign, which is MCQ of old All India exam, previously asked. So comet tail sign, but investigation choice MRI. For emphysematous, CT scan. And cholecystopathy, which is a motility disorder, HEDA scan is the investigation of choice. So investigation of choice for cholecystitis and cholelithiasis is ultrasound. For adenomyomatosis, MRI. For emphysematous, CT scan, and cholecystopathy, HEDA scan. But always we order ultrasound first, and you can see here, this is the pearl necklace sign. The Rokitansky-Aschoff sinuses having myomatosis. This is the comet tail sign of adenomyomatosis on ultrasound. These are the seen in fundus with white lines behind it. This is a emphysematous cholecystitis, air in the gallbladder, CT scan. This is the champagne. We see effervescence in the gallbladder due to air bubble. That's a champagne glass sign. Now in gallstone, we have to know gallstone ileus, one condition where there is a fistula between gallbladder and duodenum, and the stone comes into the duodenum and finally goes to distal ileum, gets stuck there, causing obstruction. So gallstone ileus is seen in old patient with recurrent cholecystitis. There's always a fistula, cholecystoduodenal fistula, and the stone gets stuck distally, causing obstruction. CT scan or X-ray will give regular triad. Regular sign is a sign of pneumoperitoneum. Regular triad is a sign of gallstone ileus. So we have a stone in ileum, dilated bowel loop, bowel obstruction, and pneumobilia. Treatment is don't do cholecystectomy right now. Just relieve the obstruction by removing the stone by laparotomy. Cholecystectomy should be done later on because of high risk of complication here. So you can see CT scan, the red arrow is showing air in the gallbladder, yellow arrow is showing stone in the ileum, and these are the dilated bowel loop. If the stone gets stuck here, in the duodenum, then it causes gastric outlet obstruction, and that's called Bauer-Barrett syndrome. So Bauer-Barrett syndrome is stone in the first part of duodenum, same causing a through the fistula. So we have air in the biliary, dilated stomach, and stone in the duodenum. That's called Bauer-Barrett syndrome. And if the stone of gallbladder due to chronic inflammation or adhesion or fibrosis compresses CBD and causes obstructive jaundice, then this is called Mirizi syndrome. So whenever there is a stone that has gone into CBD, then we get jaundice, cholelithiasis. But in this case, the stone is in the gallbladder, it has not gone into the CBD and causing local fibrosis and adhesion in this area. And that's causing jaundice. This is Mirizi syndrome. There is a Sanders classification of Mirizi syndrome where we do get fistula. Type 2 onwards there is fistula, and type 5 is actually duodenal fistula. Type 2 onwards CBD fistula, type 5 is duodenal fistula, cholecystoduodenal fistula. So here you can see there's adhesion, fibrosis, etc. This is a picture of Bauer-Barrett syndrome, stone in duodenum. This is a Mirizi syndrome, stone here but compressing CBD causing obstruction. There's another condition called Abernathy malformation. There was one question in All India. It's a congenital malformation of portal vein. So normally what happens, I'll take 15 more minutes and that's it. This is the liver. This is the portal vein, which forms with fusion of splenic vein and superior mesenteric vein, and this is the portal vein. But in Abernathy, and this is the IVC, let's say this is the IVC here. In Abernathy malformation, portal vein is connected to IVC congenitally. So one type is, in type 2, we have a shunt kind of side to side here, side to side fistula, side to side like this, congenital. So here the liver is normal, some blood is going to the liver. We just have to ligate this fistula and that's the treatment. But in type 1, this is not side to side. This is kind of the whole portal blood going to IVC. Liver is not having portal venules, so liver transplant is a treatment. So in type 1, we have two types. Either we can have a separate splenic vein and superior mesenteric vein going into the IVC, or they fuse and become one and go into the IVC. So these two are type 1 A and B. These are type 1 and this is type 2. Naturally in type 1, liver is abnormal. There are no portal vein inside the liver. So you have to go for liver transplant. In type 1, we have congenital malformations also, cardiac and polysphenia and atresia, etc. But in type 2, treatment is simple, just you have to embolize or ligate the shunt. So Abernathy malformation is congenital malformation of portal vein, where portal vein drains into IVC rather than going into the liver. Type 1 is a end-to side, two separate splenic vein and superior mesenteric is type 1A. They fuse and become one and then drain to IVC, that's B, 1B. And this side to side is type 2. There's one question. So approach wise, I think I'll leave this part already. We have discussed this in detail in different sessions. So whenever patient comes with right type abdominal pain, you always order ultrasound and you order LFT. Ultrasound showing gallstone, just operate. Immediate or interval, it's your choice. But ultrasound showing bile duct dilated or LFT obstructive jaundice. Either. Obstructive jaundice means direct component bilirubin more or alkaline phosphatase more. Don't operate unless you rule out the CBD pathology, then you order MRCP. MRCP is investigation choice for CBD pathologies. So whenever in ultrasound you have a dilated CBD or jaundice, clinically or biochemically, always order MRCP before you operate. So MRCP, CBD stone. So CBD stone, ultrasound is first, but investigation choice is MRCP. And MRCP is for all pathology of CBD, whether it's a stone or it's a stricture or it's a choledochal cyst. For all we have MRCP. For leak, ERCP is better. For cancer, cholangiocarcinoma, CT is better. And for microlith, endoscopic ultrasound is best. Microlith means you have a very small particles, about less than 2 millimeter size particle in CBD, in bile, and they don't cause cholangitis or biliary problem. They cause pancreatitis due to injury to ampulla or beta. So microlith presents with pancreatitis and they are best diagnosed by endoscopic ultrasound. This is an important point. They might ask this. This can become MCQ. Investigation choice of microlith, endoscopic ultrasound, right? So this is a MRCP. You can see the stones in the CBD clearly, non-invasive. MRCP, you don't even use a dye. This is a T2 weighted MRI. You don't use a dye. Now pancreas, another last 10 minutes. Most common is adenocarcinoma, around 90%. Endocrine tumor, most common is non-functional men polypeptidoma, non-functional. In functional, insulinoma. In men 1, most common gastrinoma, most common malignant gastrinoma, enteropancreatic gastrinoma, because it comes from first part and second part duodenum rather than pancreas. Gastrinoma, 80% they come from duodenum. There's a Passaro triangle, they come from Passaro triangle, from first and second part duodenum or head of pancreas. So enteropancreatic is gastrinoma, malignant gastrinoma, men 1 gastrinoma. Investigation wise, endoscopic ultrasound is investigation of choice for insulinoma, and that is always the first investigation. For all other type, we order SRS, somatostatin receptor scintigraphy. This is the investigation of choice. Why I am saying this? Endoscopic ultrasound is not a good investigation for tail of pancreas. VIPoma and glucagonoma, they come from tail. Gastrinoma and somatostoma, they come from head. So for tail, endoscopic ultrasound is not a good test, then SRS is better. So somatostatin receptor scintigraphy is investigation of choice for some endocrine tumor which are not detected on endoscopic ultrasound. So endoscopic ultrasound is the best and first investigation. For insulinoma, gold standard is intraoperative ultrasound, though it's theoretical. It's only gold standard, not investigation of choice. Most sensitive is pancreatic vein sampling for insulin, and gold standard biochemically 72 hours fasting sugar value. Insulin upon sugar ratio is more than 0.3. These are some points you have to remember for MCQ. Tumor marker for endocrine tumor is chromogranin A, this one. And for carcinoid also chromogranin A. Cystic tumor of pancreas, 3 main cystic tumors, serous cystadenoma, mucinous and IPMN, intraductal mucinous pancreatic neoplasm. Serous cystadenoma is common in female 2:1 ratio in old age after 60 years. And we have microcystic lesion in pancreas giving bunch of grape appearance. Cuboidal cell lining, they are rich in glycogen, poor in mucin. They don't have mucin, only glycogen. These two are MCQ, both of them. And you can see here, there is a central scar and sunburst appearance. Both are questions. Sunburst appearance in pancreas seen in which tumor? Serous cystadenoma, which is a cystic tumor of pancreas, usually from the head, bunch of grape appearance. You can see here, this is the central scar, this is the bunch of grape appearance. Both are serous cystadenoma. Now, and this is a benign tumor, so generally kept under observation. If they are big, then you can go. Nisidoblastoma and stoma are not same. Nisidoblastoma is seen in children. They cause very significant hypoglycemia. They're a little different. So, but the presentation is hypoglycemia for both. Presentation is same. They are not same tumor. So I was saying, pancreatic lesion, serous cystadenoma is benign, generally kept under observation. When they are more than 4 centimeter or symptomatic, then you can do central pancreatectomy. It's a very rare surgery done for very few conditions. This is one of them. Central, not Whippers, not distal, central pancreatectomy. Cystic pancreatic lesion, second is mucinous adenoma, again common in female, but here it is 10 times more common than in female than male. Middle age, they are macrocystic. Unlike serous, which is macrocystic, they are macrocystic. Columnar cell lining, they are rich in mucin and absent glycogen. CA is high. This is how you differentiate serous cystadenoma from pseudopancreatic cyst. Pseudopancreatic cysts also have a cystic lesion. But firstly, you get wall calcification here, which you don't get in pseudocyst. And some number 2, CA is also high, which is normal in pseudocyst. So CA can be high. Ovary-like stroma, all these are MCQ and hormone receptor positive. In CT, you have internal septation and wall calcification. So this C, mucinous adenoma, you can see wall calcification here. Here also you can see the white dots of wall calcification. And this is the internal septation here. In MRI, you can see this is a classical internal septation giving ovary-like stroma, which is MCQ. So ovary-like stroma, hormone receptor positive, wall calcification, mild malignancy risk, and cuboidal cell. These are features of mucinous adenoma. IPMN, intraductal pancreatic mucinous neoplasm. We have dilated duct, we have intramural nodule, and fish mouth appearance. So this is also common in old age, after 60. And fish mouth appearance on endoscopy, excessive mucus production rich in protein. Fukuoka and Tanaka classification are used. They tell us that this malignant potential is high. So when the size of the duct is more than 8 millimeter and solid nodule, which is a part of Tanaka classification, you don't have to know the detail if you want to remember the name only, then malignancy potential is high. So you can see the dilated pancreatic duct here. You can see fish mouth appearance of ampulla of Vater in endoscopy, and mucin coming out from, very rich in protein mucin comes out from the pancreatic duct. This is another fish mouth appearance here. So this is, and these two are also fish mouth appearance, and this is actually relatively high malignant potential. Out of these three, it has a relatively high malignant potential, so it should always be operated upon. It's not kept under observation. And CEA and CA19-9 both can be high here. Well, this is a new entity called groove pancreatitis. This can become MCQ, paradenal pancreatitis, groove pancreatitis or paradenal pancreatitis. This is a classical, this is seen in male, 40s and 50s male. Alcohol has a very strong association with this. And here the chronic pancreatitis changes we get in this area, in the groove of pancreas and duodenum. So firstly, it involves minor papilla, duct of Santoni. Secondly, Brunner gland hyperplasia, and the whole area undergoes fibrosis, and finally duodenal stricture, stenosis. So here, this is the part which is involved. Minor papilla is always involved, cyst and Brunner gland hyperplasia in the duodenum, and middle-aged male. So groove pancreatitis or paraduodenal pancreatitis is a rare chronic pancreatitis affecting the groove. Which groove? This groove, between pancreatic head, duodenum, and common bile duct. And strong association with alcohol abuse, and there's always obstruction of Santoni, minor papilla and Brunner gland hyperplasia, as well as cyst in the duodenum. It might require surgery in severe cases. This actually I'll not discuss as we are running short of time, but in acute pancreatitis I'll tell you what you should remember. Firstly, causes. If you can, it's better to remember because rarely they do us. Secondly, investigation, amylase, lipase. Specificity, sensitivity is poor. More than 3 times normal is diagnostic for amylase and lipase both, and both do not have prognostic significance. These 4 score, don't memorize the value, only memorize what are included in this. And in prognosis, SIRS number 1, number 2 SOFA, and number 3 Q SOFA. ये जरूर रट लेना, ये जरूर पूछा जाता है कहीं ना कहीं. I discuss this in pancreas and medicine, they discuss in infection and pathology, they discuss in, I mean, it will be discussed in many places. So if you see my notes of pancreatitis, you'll find SIRS, SOFA and Q SOFA and all this in detail. So ये important है, ये याद रखना. Don't memorize the value, only memorize the parameters what are included here. ठीक है? Now ये मैं छोड़ देता हूं, ये मैं डिस्कस नहीं करूंगा पैचेस स्कोर, बिकॉज so I'll only not show you some x-rays and that's it. 5 minutes. So feline esophagus, you can see multiple transverse serration here in esophagus and barium, and that is basically seen in eosinophilic esophagitis or GRD. Number 2, you must remember sliding and rolling hypertonia, as I told you earlier. Barium swallow sliding will be like this, G junction above diaphragm and rolling the G junction below diaphragm, but the fundus goes up. So these two you have to identify. Like rolling, it is like this, and sliding hypertonia. Air fluid level behind the heart, this is a feature of X-ray in rolling hypertonia. Retrocardiac air fluid level. This is a fundal gas shadow, which should be below diaphragm. Double bubble sign, ये भी आपको याद रखना है. Duodenal atresia is the most common cause, duodenal atresia, but annular pancreas and Latz band in condition may be LAD. Latz band is found in malrotation of gut, Latz and LADDS. इनमें भी मिलता है. I have kept 2 photos just to tell you, don't get confused by the volume of air. हवा ज्यादा भी हो सकती है, कम भी हो सकती है. Here air is more, air is less, both are same. Duodenal atresia type 1 has a windsock deformity, which is MCQ. Windsock deformity, windsock. Type 3A has a apple peel atresia, type 3B, sorry, apple peel appearance, this is another MCQ. So windsock is type 1 atresia, type 3B is apple peel atresia, which is MCQ. Now corkscrew appearance we get in 2 conditions in barium. One is barium swallow seen in DES, diffuse esophageal spasm, which I am sure it has already been asked and it will become MCQ in future. And midgut volvulus also we have corkscrew appearance. In malrotation of gut, midgut volvulus, corkscrew appearance. Then hydatid cyst sign, dancing hand sign and water lily sign. Dr. Sumit discusses this in detail, I am sure all of you know this. Reverse sign is a sign of graft versus host disease. Graft versus host disease जो है, this is actually, it's not a rejection. Like body rejects the transplanted organ. Here the transplanted organ rejects the body. So this is most commonly seen in bone marrow transplant. In solid organ, this is most commonly seen in small intestine, in solid organ. So small intestine transplant, this is most commonly seen, graft versus host disease. And this is the ribbon sign you get in. Now this is the whirlpool sign in midgut volvulus. Let's zoom this area in here as well as here. Superior medullary artery curving towards right. Whirlpool sign. String of pearls sign or string of beads sign is a sign of small bowel obstruction. Stack of coin sign also seen in small bowel obstruction, sometimes hematoma. Cup and spill sign is gastric volvulus. Stomach is like this, but in volvulus you see upside down stomach somewhat like this. These are the 2 gastric volvulus, like this, upside down stomach. Double duct sign, which is a, yeah, last part is fast because I have to go little fast. I have limited time already. I have gone beyond my given time. So you can see the video later on and see. So double duct sign is, this is a question also in all India. This is seen in pancreatic cancer, especially in head cancer, where both the ducts are quite prominent, the pancreatic and CBD. Sausage shaped pancreatitis is a feature of autoimmune pancreatitis, which is a part of IgG4 RSS, immunoglobulin related, G4 related systemic sclerosis, autoimmune pancreatitis, sausage shaped pancreas. Into susception, we get target sign. We again get target sign in CT. In CT, we can get a yin yang sign. Yin yang, the Chinese sign, one sign dark and one side light. Claw sign, yeah, this is an important sign. ये आपको पता होना चाहिए, claw sign. So this is a claw sign here. In CT scan, the barium will go into colon, descending colon, and forms a claw like this. So this is a claw sign. Coil spring sign we do get in hematoma as well interception both. So all this we have discussed in regular batch actually. All this I have shown in regular batch during discussion. So nothing new here. 1 or 2 point new. So in hematoma as well as in interception we get coil spring sign. Not duodenal hematoma, any intestinal hematoma. After trauma, after radiation or interception. So I can zoom it in so you can see coil spring sign here. Beckett's Fenn sign again is a feature of intramural hematoma when the bowel hematoma is in the wall. This again is an important X-ray coffee bean sign or kidney shaped shadow. This is a sigmoid volvulus. Bird beak sign is another sign of sigmoid volvulus or cecal volvulus. Yeah, I think they'll upload the PDF, which I guess they'll upload the PDF. Northern star sign is another sign of volvulus. Northern star means this is the transverse colon and the sigmoid goes above transverse. This is the sigmoid tip. So this is the sigmoid tip here, which is above the transverse colon level. This is called northern star sign. And this is sigmoid and coffee bean sign and all these are. Sawtooth appearance is a sign of diverticulosis. This again is an important MCQ. I mean, this can be shown to you. Bowler hat sign, which is somewhat like this. Like this. You can see here in this circle. This is for sessile polyp and Mexican hat sign is for pedunculated polyp. So Bowler hat sign and Mexican hat sign for sessile polyp and pedunculated polyp. Apple core sign is a sign of barium enema in cancer. When you have circumferential growth here, like growth here and here, so that then you get apple core sign. And both the pictures are showing apple core sign beautifully. So just 2 lines for all of you, just 2 lines for inspiration. You have chosen a branch which is very noble and very satisfying, believe me. Only thing it needs is hard work. So you have to be little committed and hard work. You have to be prepared for hard work. So once you become doctor, you start treating patient, you will get lots of satisfaction, believe me. And it's money-wise also it's not bad. You have to be little patient and you have to be little hard-working. There's no shortcut in this field. So remember, all not superheroes, they don't have capes. Some wear dresses, especially OT dress. Surgeons wear OT dress. Okay? So never stop. One day you will be someone's hope and someone's hero. Bird beak sign we get an interception because in volvulus you don't do barium enema. In volvulus you do barium, you'll follow through. You get corkscrew appearance. So bird beak sign you get in volvulus, sigmoid volvulus, not interception. Volvulus, sigmoid volvulus or cecal volvulus. Slip of tongue. Bird beak sign is a feature of sigmoid volvulus or cecal volvulus and barium enema. And second is achalasia cardia and barium solo. So if you have any question you ask, I must say sorry to Dr. Sadeep, he is waiting for quite some time to take a session. So any question you have, quickly you ask, otherwise all the best to all of you. Yeah, sigmoid right side concavity, this is a question from Nirja More. You Nirja, listen carefully. This is the abdomen. Normally sigmoid volvulus is like this. This is a volvulus. So we get a picture like this and we call this anti-clockwise rotation, which is more common. But sigmoid can very well be like this as well. So that is a clockwise. Sigmoid can be anti-clockwise, clockwise both. But cecal volvulus is always clockwise. Cecal is always clockwise. But sigmoid can be both. But more often on the right side, anti-clockwise. Okay, done? So, all the best to all of you. And thank you, Dr. Sumir.